Hi, everybody. I wanted to do a real quick um, PowerPoint presentation for you on infusion therapy. And this is going to be for exam 2 coming up. So here are some quick points for you to consider regarding infusion therapy. So some of the purposes that we consider when we talk about infusion therapy are maintaining the fluid balance for the patient, or actually correcting the fluid imbalance, maintaining electrolyte and or acid-base balance, or correcting electrolyte or acid-base balance. We also use infusion therapy for administration of medications and replacement of blood or blood products. We need to use our clinical reasoning and consider a few things when we think about putting in a peripheral IV line. And some of those things are, what are we going to be giving through that IV line? How long is the patient going to need IV therapy? What kind of fluids are we going to be giving? And what are the rates of the administration that we might be giving? And then we also need to think about the patient themselves. Are they an ambulatory patient? Are they confused? Are they a dialysis patient? Have they maybe had a mastectomy? We need to consider what their baseline is so that we might be able to place an IV that's more helpful to them. So when we talk about adults and IVs, we're looking at either the hand or the arm. We usually try and start low in the hand and then work our way up the arm. The lower we start, if we start high, we usually can't go lower than an IV. If we blow a site, we can't go low. If we're talking about infants, we are talking about scalp or the dorsum of the foot. And then we also need to consider exactly what type of solution we're going to be running, the speed of the infusion, and how long the IV is going to run. So there are certain types of infusions that have to go in a larger vein. So that would mean that we automatically go to the antecubital area or go for a more special type of IV type. And if we're going to be running an IV at a high rate, then we're also going to go for a little bit larger vein, which might mean further up the arm. So those are all things that we would consider. So when we're looking at IV catheters, I've got a picture of a typical IV catheter at the top of your screen. 14 to 16 gauge catheters are usually used in trauma and ER. Sometimes they're put in the surgical areas, but typically we don't use those on the floor. They're used for running in fluids at a high rate of speed. Resuscitation speed. You need to make sure that you've got a vein that's large enough to handle that catheter. 18 gauges are, this says it's preferred for surgery. We can also put those in on the floor. And again, you need to be aware that you need a vein large enough to accommodate the catheter. Typically what we use on the floor and even back in CCU are 20 and 22 gauge catheters. They're usually 1 inch to 1.25 inches in length. They're typically adequate for all therapies, even blood. We can infuse blood without damaging the RBCs as they go through. We can also use catheters as small as 24 to 26 gauge. These are about 3/4 inch. They are the smallest, the shortest. They're not ideal for viscous infusions. If you do infuse blood, which I've never really infused blood products through an IV that small, but just know that it's going to take longer. But these smaller gauge needles are also more preferable for infants and children. So this is a picture that is just a diagram of some of the veins that we try and use when we're looking at hands and arms. This is just for you. When we talk about continuous IV infusions, we talk about why we have them. And first, you need to know that this has to be ordered by a provider, and a provider needs to give you a complete order. So a provider, physician, or clinician that is licensed to put an order in. So because this has to be ordered, you have to treat it as if it's a medication. So you have to observe the 6 patient rights, make sure it's the right patient. We know it's the right route, the right fluid, the right time. If it's continuous, then it's going to be running all the time, and you're simply going to swap out a new bag for a bag that is completed. You have to document the time that it's completed and the time that you put the new bag up, and make sure that you document. You're always going to barcode scan the patient, and then barcode scan the medication that you put up, and that way you have the computer system doing your double checks for you. Your continuous IV is considered your primary line. This is the main line, and that runs continuously. You might have a secondary line, and that's usually considered the piggyback line. We usually use that for either additional fluids or medications that can run all the time. Sometimes you have a continuous line and a secondary fluid like possibly heparin, or you might have an IV antibiotic that's running maybe once every 6 hours or once every 8 hours. We typically leave those bags, we turn the secondary line off when it's not in use and leave the bag on the IV tubing and keep that system closed. We keep that all together. When you initially hang the tubing, you want to back prime the piggyback tubing from the primary line, so that you keep that system closed. This is going to reduce the risk of infection by keeping that line closed. So just know that back priming from the primary line reduces the risk of infection. This is the best way to do that. Once a continuous line is DC'd, a lot of times we want to keep the IV access in. So we'll discontinue the IV line itself, but we'll convert the IV access to a saline lock. And here's a picture of a saline lock. Also know that for your patients that maybe not be fluid challenged, or we can't run a lot of fluids in, you might get an order for an actual saline lock without a continuous IV, and this is, again, what it looks like. But we also have different types of catheters that we can put in, and central venous access devices, and I know Mrs. Windmiller has already lectured you on this, but I just want to touch on them. We have peripherally inserted central venous catheters, also known as PICC lines, non-tunneled central venous catheters, tunneled central venous catheters, and implanted ports. So a PICC line is usually 18 to 29 inches. And all of these lines have to be verified through an X-ray before you can run any kind of fluid. Keep that in mind. You have to have an X-ray to verify placement before you can run any kind of a fluid. Otherwise, you risk giving the patient a tamponade if the placement is wrong. PICC lines are put in by specialty trained nurses. So a non-tunneled central venous catheter is usually inserted through the subclavian vein in the upper chest or the jugular. Sometimes they're put in through a femoral vein. These are usually done in an emergent state, and we typically try and change these out within 24 hours because they do have a high rate of infection. They're usually 7 to 10 inches long. And up to 5 lumens. The tip resides in the superior vena cava, and again, the chest x-ray to confirm placement. We have tunneled central venous catheter lines, and this is a newer version of just a plain old non-tunneled. We like these better because it gets the point of insertion further away from where the tip actually goes into the a subclavian or the superior vena cava. These are actually, the patient is taken to surgery, and this is done with sterile technique. You can see in this picture where the piece of tape is indicated on the chest is where the catheter actually goes into the chest wall, and it's tunneled underneath the skin and then enters several inches above. So these are used for frequent and long-term infusion therapies, and they also have a cuff of antibiotic-containing material to help reduce infections. They usually have multiple ports. And then the last type are implanted ports, and these are for very long-term use. They consist of a portal body, a dense septum over a reservoir, and a catheter. They usually come in double and single lumen. They're surgically put in, and there's a pocket created usually in the upper chest. And they're accessed through the skin. In the bottom left-hand corner, you can see a picture of I think this is probably well, it says a Power Lock safety infusion set. We also access with Huber needles. And it is a little bit of a needle stick through the subcutaneous skin, but it's much better than an IV stick for the patient. And actually with an implanted port, well, yeah, you do have to confirm right away with X-ray, but after all of these are confirmed the first time, you no longer have to confirm every time you use them, just the first time. So I want to go over some of the local complications of IV therapy. Those are infiltration. We want to make sure that the IV is patent and that we're able to run IV fluid through the site and it's going venous. Extravasation, that is where the fluid or the medication would be running into the tissues around the IV site. A hematoma would be a blood clot or bleeding at the site. A phlebitis, again, would be a blood clot at the site. Thrombophlebitis would be blood clots running up the vein. We can also have nerve injury. Usually that happens as you put the IV start in. And if you have a patient tell you, oh, that hurts or that makes my hand numb, as you're doing an IV site start, go ahead and pull out and just go to a different site. It's not worth the risk of doing some permanent nerve damage and having them possibly complain about that. And then we also run the risk of local infection at the site of the IV. So we can also talk about systemic complications of IV therapy, and those are septicemia or infection throughout the system. We can also overload the system with fluid, especially for those patients that have heart failure or are very sensitive to fluid overload. We can, if we introduce a large amount of air, we can give them an air embolus. And we can also have part of the IV catheter break off and become an embolus and float through the system. So those are all potential complications for IV therapy. Administering IV medications, just a few things I want to talk about. Of course, we have to practice medication safety, and that, again, goes over the 6 medication rights. Know that we can give drugs rapidly, including fluid rapidly. So we have to be able to watch for the effect of the drug quickly. In order to do that, you have to know specifics about each IV medication that you're going to be giving. Those include the drug itself, the dilution that you may or may not be using, the rate of administration. You have to make sure that the drug you're using, you know, the compatibilities and what's already hanging with the patient. And then any type of monitoring requirements, whether that's monitoring at the time you're giving or monitoring directly after that. Does your patient need to be on cardiac telemetry monitoring? Those types of monitoring requirements. You also need to know when not to use a vein, and I think we probably have talked about this, but I just want to reemphasize that a patient that has had a mastectomy, we should not be using a vein in whatever side they've had a mastectomy. Now, if they've had a bilateral mastectomy, we may not have a choice, but if that's the situation, you need to get an order from the physician that it's okay to use that. We may actually opt to put some kind of a central line in that patient. We also are not going to use an arm on the side that the patient has had an axillary lymph node dissection. If the patient has lymphedema, we're not going to use that side. If they have any type of paralysis of the upper extremities, we're not going to use a paralyzed extremity. And lastly, we're not going to use any site that has a dialysis graft or a fistula in it. For those patients that are on dialysis, those grafts and fistulas are their lifeline. If we mess around by putting IV lines in those, we could actually do great harm to that. So we do not do any kind of an IV site on the extremity that has those. So administering IV medications, oops, I'm sorry, I went the wrong way there. And that is the last slide. So I hope this helps. You have an exam coming up, and hopefully we've covered everything on this quick little ditty for the exam coming up. Thank you. Bye-bye.